Hello, everyone, and thank you for joining this CENTO webinar. Today, guest speaker Professor Löhr of Karolinska Institute and co-host Professor Peter Bauer, Chief Scientific Officer of CENTOGENE, will be discussing pancreatitis, a genetic disease. If you have any questions during the presentation, please enter them into the Q&A chat located at the bottom of the screen, and we will review your questions after both presenters have finished. So I will hand over the mic to Professor Löhr. Let us begin.
Thank you very much. It is my pleasure to talk today about pancreatitis, a genetic disease, and I would like to cover some areas. No, I cannot. I would like to talk a little bit about the physiology of the pancreas, then the genes which are involved in what is commonly called hereditary pancreatitis. And then I will cover some rare diseases and even show how one can apply genetic diagnostics to some unclear cases. To start with the physiology, the pancreas produces up to 1.5 to 2 liters of liquid, that is fluid, every day, mostly during the meals though. It's an alkaline pH juice, which is secreting bicarbonate, and then also the enzymes which digest carbohydrates, proteins, and fats. There are also the islets of Langerhans, which produce the insulin, which most of you will know. But for the matter of pancreatitis and this talk, we shall focus on the pancreatic enzymes, and that is the exocrine pancreas. Now, when it comes to chronic pancreatitis, the incidence is about 40 or 100,000 inhabitants per year, which makes this 185,000 a year in the United States. The peak is in the 5th to 6th decade. The prevalence is about 80 of 100,000, which makes it, for instance, in Sweden, some 80,000 patients with a 9 to 10 million population. Just for comparison, to get an idea and a feeling how frequent this disease is, with diabetes, you have around 4,000 per 100,000 inhabitants per year, and pancreatic cancer is much less. It's about 10 per 100,000 inhabitants a year. We recently issued the guidelines on chronic pancreatitis from the United European Gastroenterology, and there you will also find something about how to define the etiology of chronic pancreatitis in adult patients. And it also says, for instance, that one should take a comprehensive medical history, laboratory evaluation, and imaging. And the laboratory evaluation, as you will see a little bit later, is also including genetic testing, if so deemed appropriate. Now, as to the etiology, most of it indeed is alcohol. That's the light color here. Then you have idiopathic. You have also anatomic variants and also autoimmune, and a very small portion is hereditary, just about 2%. And this really makes up, the problem here. And of those which are unknown, the hereditary makes up the largest part, really. Now, one also has to go back a little bit in history to understand, and this is as actual as it is today, that the autodigestion really is at the heart of what makes up pancreatitis. And this is then already coming to the digestive enzymes. And you can see here a blow-up of one of those acini, and these are the cells which are producing actually enzymes, then leading to a pancreatic duct, which eventually would drain into the duodenum, that is into the intestine. And here is this enzymatic cascade, which we will have a look at a little bit closer in a minute. And basically, the defects which can give rise to pancreatitis lie within the acini or the duct cells, as we'll see in a minute. So in the cascade, you have entropeptidase, which is then activating the trypsin, and then this cascade is further going on, chymotrypsin, chymotrypsin, proelastase, and so forth, all the way to lipase. And these are exactly the defects which make up the genes involved in which we coin hereditary pancreatitis. This all began with a family described, and for you being geneticists, you know this very well, in the 50s, where these patients had pancreatitis. And as you can see here, this was the first family described, 52. However, it took until 1996 when David Whitcomb described the first gene, which was in the cationic trypsinogen gene, published in one of the first in Nature Genetics, really. And you can see the family here. Now, what does this enzyme do? And it's exactly this trypsinogen, which is a so-called gain of function, which then causes to be there more trypsin, which then in turn will lead to activation of the digestive enzymatic cascade and then cause the pancreatitis. So this is the gene here, as you can see, and next to it is the inhibitor, PSTI, which you can see here again, which is another a gene which can be affected. It's a serine protease inhibitor of the Casal type. That's what the SPINK stands for. And it's normally inhibiting the trypsin prior to activation. And this, of course, then is a loss of function here, because if you have a mutation here, there would be more active trypsin, and it cannot be inhibited and or degraded appropriately. So the effect is about the same as would be there with the gain of function in the trypsinogen gene as such. Further down the cascade, we have the chymotrypsin, which can be another gene which can be affected by genetic diseases and heredity to cause pancreatitis. Here again, you have a loss of function, because then it cannot digest the trypsin. So again, you have more activate trypsin, which then again would do the very same thing, lead to autodigestion and contribute to pancreatitis. So those are in essence the acinary components here. There are even some which prevent for the development of pancreatitis. And then we have the ductal compartment. And this is more or less already leading to rare diseases, and cystic fibrosis is one of them, even if it is the most frequent monogenetic disease in the Caucasian population. As you may know, it's affecting many genes, namely the lungs and the testis, leading to male infertility, but it is also affecting the intestine and particularly the pancreas. And here, again, it's an autorecessive disease. It is the transporter, the chlorine transporter, which is affected here, leading to quite some severe damage of the pancreas as it does damage the lungs. And there are some of the genes which do affect the exocrine pancreatic function. In others, this is not the case, really. So some of those are very severe, and others are rather mild of those mutations. And then you can see that there is a different frequency of pancreatitis in these kind of patients. One should do, if so suspected, a so-called sweat test, which is obligatory, and it's also recommended by the guidelines to do this in juvenile patients with chronic pancreatitis, where you do not find any other etiology for the disease. Now, if you now look into patients, and particular children, with hereditary or idiopathic chronic pancreatitis, you can see there is this frequency of genes affected. The SPINK, the CTRC, CFTR, another one which we'll talk about in a minute, the PRSS1 and the CAP1. But this is then the frequency in the background population here, as you can see. So there are some of those genes also found in the population, and this is the relative risk, how it is increased in the patients. Now, what is also important to know, that there are patients who have more than just one mutation, and that's a little bit complicating things, but normally you would do a screen in those patients where you would not only test for one, but maybe for all of those known genes which could be altered. But there may be combinations, particularly SPINK is often seen with other more major quote-unquote changes, say in the CFTR or in the PSS1, or even in the CTRC gene. Again, coming back to the guidelines, the question now being in which chronic pancreatitis patients genetic screening should be performed and which genes should be investigated. And there, all patients with a family history or early onset of the disease, that is before the age of 20, the first 2 decades, that is, of life, should be offered genetic testing for associated variants. And from the guidelines, there is not that much recommendation. The evidence is also weak, but there was strong agreement amongst the experts. So, and then for the young patients, what etiological factors should be investigated in pediatric patients with recurrent acute pancreatitis, and there again referring to cystic fibrosis, which must be ruled out with genetic testing to really make sure that this is not an underlying severe disease in these young patients. If you look at all of the possible mutations which are out there and have a look at the effect size, which may be rather high, and the allele frequency, then you have this slide here, where you have, for instance, something which is has a high effect as CFTR here and is relatively common, one can say, and on the other hand, you have other genes which are maybe not so common in relation to other diseases here, for instance, not in Crohn's disease, and others in prostate cancer or even Alzheimer's. So with regard to those, for instance, the CFTR, again, has a huge effect and is somewhere in the middle of these allele frequencies, really. If you look at the distribution of age of onset in chronic pancreatitis, in the non-alcoholic one, this is the group which should be tested, and this is exactly referring to what I explained before, the first 2 decades of life. Those are the ones which should be tested, or offered, I should say, genetic testing. There's another implication, particularly for the PERSIS1 mutations. There is a risk to develop pancreatic cancer later in life, so these patients must be identified and followed up. They should receive also some counseling as to not to smoke, because this is very much increasing the risk of later in life developing pancreatic cancer. So this has a very concrete impact on the life of these patients. Another thing which is common to all genetic testing, just to show you, of course, what can happen is that you detect a mutation in a patient and the parents are both wild type. And one wonders then, for instance, whether this really might indeed be the right father. That would be one of the explanations. Of course, we do know that some of those mutations are indeed de novo mutations. Now, coming to other rare diseases, there is a very severe disease, that is severe acute pancreatitis, which can be due to hyperlipidemia, and there are some of these syndromes, and one particularly can be measured quite nicely, the LPLD, for instance, where you have markers which then can be identified and then measured. And this has also, for the familiar hyperlipidemia in these patients, a very clear impact on the patient, because for some time now there is the first approved gene therapy overall in Europe, Pancreatitis, which then would give these patients the chance to correct this gene defect and have a life without these severe, damaging, and life-threatening bouts of acute pancreatitis. Now, there's another gene which is combining both the diabetes and the pancreatitis, which is in the CL, in the elastase gene. And again, this was a family described a couple of years ago by a Norwegian researcher. And this also, if you have a patient who has both a pancreatic exocrine dysfunction and a newly detected diabetes mellitus, then this would be something which should be tested, a rare disease, but affecting both the endocrine and the exocrine pancreas. You can also use this to find some very novel things. For instance, some years ago, we have described a patient who had indeed a CFTR mutation plus a thalassemia gene mutation, and that could explain the pancreatitis in this patient, which only occurred when this patient was flying in non-pressurized planes in Africa. So this gives you sometimes a nice explanation for some of these cases. Beside those, there are quite a few syndromes, which you can see to the left-hand side, which can be identified on the basis of their genetic markers or abnormalities. The Schwachman syndrome, ataxia, for instance, others, which you see here, with both may have a diabetes and or a pancreatic exocrine insufficiency, that is, not a pancreatitis as such, but a diabetes and some pancreatic exocrine insufficiency. So if you have this combination, again, some of those patients will have a very distinct physiology and a distinct phenotype, but sometimes this may be rather subtle. It would be a good idea to do some genetic testing in these patients. I think this is all I have to say, and I think I have to hand over now to Professor Bauer.
There's different aspects that need to be addressed right now when we look into an appropriate testing scenery. And one is, of course, and that's the basic of all testing, that we have to implement a workflow and streamline the workflow, that the information we get around the cases is collected. We manage logistics and, of course, the clinical data, and then put the genetic test right in the middle of what we are doing to get an appropriate and precise report. And as Professor Löhr said, we have a lot of questions around pancreatitis, whether this is oligosymptomatic or recurrent, whether we have diabetes, or whether it's rather the exocrine function and inflammatory part is not so defined, rather pointing to the lateral list of rare diseases such as diamond or Alström syndrome or cases like that. So this is something we have to organize and give, of course, feedback within a short period of time, especially with pancreatitis, where, of course, sometimes the exacerbation is very severe and life-threatening. So the other part that I want to briefly touch before we look into details of the technical tests is that, of course, logistics is very important, and there with a filter card-based test like we offer it with our CENTOGENE, they have clearly an advantage in very stable shipment. We can even look into metabolomics of these patients, which are altered in pancreatitis, and so give us insights into the pathophysiology of these patients, and can do all the genetic tests necessary for pancreatic patient in small amounts of these dry blood spots. Now, it has been pointed out that it's not a single monogenetic disease triggering pancreatitis, but rather there is usually the question whether an early onset has exogenic or genetic triggers, and therefore a panel approach is meanwhile as well expert recommendation in the guidelines. You might be aware that different types of assays can be offered, and we at CENTOGENE we worked a lot on NGS panels, which we call NGS Panel Plus, where the complete coding sequence is covered, including all known, sometimes intronic the pathogenic variants that have been associated with the phenotype in the past. So you really get a complete picture of the knowledge, up-to-date knowledge on the genetics of pancreatitis when ordering such a panel. Sometimes we have to fill in sensitivity gaps by doing then a PCR-based test. And the most interesting genetic format, of course, would be whole genome sequencing, because this does not only cover the known exonic parts, but as well everything around that gene in terms of introns and regulatory elements. And I will come back to that option, or at least questions around the future implementation of genome sequencing, my last slide. You can be aware that with this full coverage on exonic variants and as well known mutations, we can offer you really a highly sensitive test. And as Professor Löhr told us, the question whether pancreatitis is hereditary or not is rather something where you have to exclude the genetic part, because you can't exclude the idiopathic part, which is usually then an exogenic trigger. And so this really points to the necessity to provide a high sensitivity test for these patients. Now, also the number of genes is right limited, at least the diagnostic genes. We heard of 4 genes, CFTR, CPA1, CTRC, and PRSS1, and the 5th one, the modifier SPINK1. Nonetheless, we can see that they all cluster in the same, at least x-axis of this allele frequency effect size picture that has already been presented. So you remember the CFTR variants that cause cystic fibrosis. They are pretty rare, but they have a very high odds ratio. This means whenever you carry such an allele, you will have symptoms of that disease, because the penetrance is 100% or close to. Now with pancreatitis, we have similarly rare variants in PRSS1 and CTRC and CPA1, which are as well a higher risk to develop, maybe not as high. You've seen the odds ratios in the table of Professor Löhr as CFTR for cystic fibrosis, but this is something we would call a monogenetic trait, while you've seen that SPINK1 giving an odds ratio of roughly 5 has already a reduced penetrance, and heterozygous CFTR alleles as a risk factor for pancreatitis will be even more reduced in the penetrance. This is interesting to mention, because we have to clearly make a distinction between the high-risk CFTR variants for the cystic fibrosis phenotype, then as a recessive trait, and the dominant risk factor for pancreatitis, which would be a reduced penetrance risk. So having that in mind, of course, we and the scientific community discusses what are factors that trigger a patient that has a recessive or a hidden CFTR variant to have a pancreatic outburst. And there we discuss especially factors that change the expressivity either of the gene with the variant, or change the expressivity of the wild type allele on the other chromosome. And so at the moment, we still have no answer on these factors that drive the expression of these risk factors. We think that the contribution of regulatory elements will be modifiers of disease. So this can be cis effects on the same allele, or trans effects for the non-expressed or not in the right amount expressed wild type alleles, and thereby trigger a susceptibility for disease. And you can see that in this context, we are talking of regulatory non-coding variants, and therefore this is exactly the gap where we have to go into with whole genome sequencing to assess non-coding variants and to link them with recurrency in patients with manifestation of pancreatitis. This is the research concept where CENTOGENE has as well contributed in projects to do whole genome sequencing on these patients, and also we can't share yet information on that. We believe that the genetic test of the future will be an integration of coding and non-coding variants, just then summing up an individual risk of a carrier of the SPINK1 or CFT allele to develop pancreatitis, and then to allow him to modify the risk by any protective measures may be taken during life to avoid these really serious and dangerous events.